Hi, Rachel. Thanks so much for joining us today on the show.
Oh, my pleasure. Thank you.
Yeah, it's really great to have you. I thought a great way to start is just to have you introduce a little bit. I've been following your work actually for a number of years, but I'd love for you to just introduce in recent years what you've really been focusing on in your research and what you're really getting interested in and what you're thinking about lately. Uh, Obviously, this talk has a lot to do with the conversation around trauma, and we have obviously a lot of questions for you. But why don't we just start off with hearing where you've been in the last few years?
Sure. I'm happy to tell you. I've been working on post-traumatic stress disorder for decades now, really a long time. And I started with one of the first groups that were doing very early work on the biology of PTSD, then a new and controversial disorder, and really have spent a lot of time trying to define, if you will, a biological phenotype or characterization of what post-traumatic stress disorder looks like in the brain in terms of hormonal changes, neurochemicals, things like that. This work led us to try to look for biomarkers that could be measured that might be useful clinically. It led us to trying to identify biologic treatment targets that could be the basis of novel therapeutics or novel treatment approaches. And as science got more exciting in terms of methodologic offerings, we have more recently begun work where we are trying to examine kind of the convergence between blood biomarkers that we have developed and biomarkers that might be present in induced neurons. And we can use stem cell technology now to take skin cells from people and induce neurons and stimulate those neurons with stress hormones as we do with our blood cells. And really look at that. I've been interested in really persistent effects of trauma, including to the next generation. And in terms of treatment options, we have really tried a lot of things based on some of our work with stress hormones and also other approaches. But most recently, I've become interested in the possibility of psychedelic psychotherapy for post-traumatic stress disorder. And we haven't pursued it yet, but we're getting started to kind of put everything together in terms of everything that we've learned about the biology of trauma and PTSD and try to get a more coherent treatment approach as a result of all that work. So that's what I'm up to.
Well, thank you.
Yeah, sure.
I'm grateful I've been, as you know, I'm a psychiatrist and I've been following your work for at least a couple of decades. And it's just, it's very inspiring to get to have a conversation with you about what you've learned over this time.
Thank you. That's nice.
Yeah.
I'm a psychotherapist, Rachel, which I don't think you knew that, but so I've been in more of the trenches with clients and doing a lot of trauma work over the years. And I'm very fascinated by this intergenerational link and what we know and what we don't know, and what I'm seeing in the office over the years, and just how more and more as I clue in to this possibility that trauma exists now over generations, and not even making a lot of not forming a lot of opinions about how that happens, but more so just how do we deal with that and address that, and how do we spot that even
Yes.
in our patients. And so I'm just curious, just any reflections you have on what I'm saying about that, and because you've obviously spent some time with it.
Yeah, quite a lot. That whole area of research, the so-called intergenerational trauma, some people call it ancestral trauma, names for it. That work began really quite by accident for me many, many years ago. when we were studying Holocaust survivors, developing a clinical program for Holocaust survivors, and getting phone calls from their children insisting that they were casualties of the Holocaust too. And we didn't at first understand it, but then we decided to study it and ask for some real clarification from people that we were seeing about what that meant to them and how the trauma of the parent impacted them. And at first it was just the regular stuff you would imagine, that if you have a parent that is him or herself traumatized, this might affect their parenting, it might affect the way they see the world, their level of optimism, just kind of very psychosocial explanations for the phenomenon. But as we began to look at some blood changes, we saw that there were very similar changes in Holocaust offspring as in patients with, let's call it first generation PTSD. And again, could still use the psychosocial explanations for this. Adult children of Holocaust survivors describe being raised in homes that were sometimes very dark and sad. And so that could be traumatic or certainly stressful. But as the field started to give us more molecular tools for looking at molecular mechanisms, epigenetics, gene expression, we began to ask questions about what might be the origin of some of the biologic changes we were observing. And everything is very correlational, cross-sectional, not the kind of work that if you were designing it from scratch prospectively you would do. But we did ask those questions, and I think finally made a big impact when we showed that there were epigenetic changes in the adult children of Holocaust survivors that were on a similar region of a gene as we found in their very own parents. And that kind of changed the conversation. That kind of got people's attention a little more, because it provided the possibility that there may be effects of a trauma in a parent that are actually passed intergenerationally, or that something happens at a critical time in a parent. For the mother, it might be during pregnancy, or it might be early before puberty, that might affect the oocytes, and then after conception kind of influence the fetal placental interactions and result in enduring changes. So what you do about that? Well, the first thing is you try to understand it. It's number one validating that people had an understanding that the things that happened in prior generations to their parents and grandparents, and maybe even further on down the line, matter in some way, are relevant, not just as a historical narrative, but as a biologic reality. So that seems very important. So that's what you do first. But the second thing is that you try to understand it. And I think one of the biggest challenges of this work is to ask the question of whether these epigenetic or molecular changes that we can measure, though we don't know how they got there exactly, whether these constitute really resilience markers or adaptive capabilities, or whether they increase vulnerability to psychopathology. And what I would say about that question, although people do not like to hear this, is that it's both. Because we like to have one or the other. We like to know whether something is good for you or not good for you. And I think what's been very interesting and challenging about this intergenerational work is that the concept of really being affected by generational trauma, or even if something was passed, which is a theoretical possibility, but we have not demonstrated the mechanism, what that would mean. Are you being given a gift or are you being given a liability? And again, the answer is that you could be given both. It depends on the circumstance in which you have to use this gift. So you can imagine that if your ancestors, your parents had to fight for their lives, they might want to transmit something that might help an offspring fight for their lives. But that would be a better gift if the offspring were indeed fighting for their life and not in a situation where they don't need to be that on guard or vigilant. So again, trying to work with what you've been given clinically and understand kind of the upsides of it and where it can increase vulnerability. When I speak to clinical audiences, sometimes, I'm aware material can get technical. I feel compelled to always explain it because I don't like how simplistic the conversation can be sometimes. Imagine a father giving his 7-year-old a sharp switchblade for his birthday. I guess in one sense, that's a terrible gift for a 7-year-old child because the most likely scenario is that the child might hurt himself. But let's say there is gang violence, or let's say the family's in the middle of being displaced or in a war or in surviving the Holocaust in the woods. Then a switchblade might really make the difference between life or death. So when we talk about the biologic changes and even some of the epigenetic changes that we may see in, adult children of trauma survivors, we're just talking about a knife, right? We're not necessarily talking about whether the knife will end up serving someone in a positive way or end up causing more of a vulnerability. So that's an incredibly nuanced way to approach biology, but I think that in order for us to have any kind of real conversation about some of what these findings mean, that's the level that we're going to have to engage in. We're going to have to resist thinking about a biologic process, that it's maladaptive versus adaptive, or that this is part of a pathology versus part of resilience, and understand that just the fact that the body is able to kind of make changes in response to trauma, or even be able to pass some of those changes on, is in itself evidence of remarkable adaptational capabilities.
That makes a lot of sense. It actually has me thinking about, and please correct me if I don't have this right, Rachel, but it has me thinking about the work around cortisol receptor sensitivity,
yes,
which I believe is one of the findings that has been shown in children of trauma survivors.
Yes. So the very, very first work that we did in PTSD was really about showing that the glucocorticoid receptors are more sensitive. So what this means is that the system is remarkably adaptive, that there are changes that occur in response to trauma that probably represent some attempt to recalibrate. The experience of trauma is really overwhelming, and the stress hormones are involved in almost every single type of activity that your body does, from being involved in mood and cognition and inflammation and cardiac function. Really, stress hormones affect so many things. And so the idea that there are changes in sensitivity that might really offset, in some cases, extreme damage from stress, or might, in other cases, really promote greater resilience, is a really complicated idea, but it feels like a true idea, because I think that when you start to speak with trauma survivors, you don't get just this monolithic everything about trauma is bad. You really, when you talk to trauma survivors, many of them are able to have taken positive lessons away from even the most adverse experiences.
I think that's a really important aspect of this conversation is the meaning making around what we call traumatic experiences.
Yes, absolutely.
Yeah, and it brings a reframe, which I think a lot of the thought leaders in the trauma space are talking a lot about right now, into more post-traumatic growth models. And I had a conversation with Peter Levine probably 8 months ago, and he said out of the thousands and thousands of individual sessions he's done, almost everyone came out basically saying that they grew from the experience.
Yeah, sometimes in a painful way, and it's also sometimes very legitimate to question whether the experience was worth the growth, right? So, I mean, that's just a really fair question for anybody to ask themselves. But the idea of finding some way for the experience to then allow someone to do something that they never would have been able to do otherwise, or think about things in a way that would not have otherwise been possible. I mean, that's where you start to be able to grow as a result of having undergone the experience. And I mean, many trauma survivors want to turn around and have this very profound instinct of trying to do something beneficial for people who have been exposed to the same traumatic experience. So I think exposure to trauma can deepen our empathy for other people. That's not the first thing that happens, though. The first thing that happens, though, is people become very self-focused because what they're going through is terrible. But eventually, I think there is this other aspect where you can really reach out and touch someone's humanity because you yourself know what it's like to really feel.
I'm curious, Rachel, what got you so interested in PTSD research?
Oh gosh. Well, yeah, I don't have a personal story of trauma to tell you about that. I began studying stress hormones in graduate school. I was doing laboratory-based work with animal models of stress. And at the time, this was in the 80s, I guess, a long time ago. The big questions concerned how stress hormones that are released peripherally from the adrenal gland can revert back and influence the brain, which, when you think about it, is a wildly profound idea that there's a two-way street between the brain and the endocrine glands, right, where there's a real loop and modification. And so that was a time of just the very early studies on that. But I really felt that I wanted to apply this to people. And so somewhere towards the end of my being in graduate school, I was looking for postdoctoral opportunities to apply this knowledge to stress, which seemed like a very universal and ubiquitous problem. And I ended up at Yale Medical School in the laboratory of John Mason and Earl Giller, who were actually the people that published the first biologic study of PTSD in 1986. So that was exciting for me to learn about post-traumatic stress disorder. I didn't know what that was. And of course, it was a very challenging concept because the ideas about stress at the time were that after the body is done responding to an acute challenge, after the stressor is over, there are attempts to kind of recalibrate and go back to normal. People talk a lot about fight or flight, which is the classic stress response. But the hormones that are released in fight or flight, come back to normal within a few hours after a stressful challenge. But post-traumatic stress disorder was a concept that wanted you to believe or know that there is something that happens outside of fight or flight that lingers, that lasts for a long time, in addition to mounting a hormonal response that helps you cope with the immediate needs of a challenge, which are basically to stay alive. There is also other things that happen that are more transformative, that are not based on just going back to where you were. So it's like there's two conversations about stress. One is the conversation that the body knows how to deal with stress, and the fight or flight response is completely elastic and allows you to mount a stress response and achieve, they call it homeostasis, go back to where it was. And then there's this other aspect that says, no, I've got to learn from this. I'm not the same. And I can't approach life exactly in the same way. So it's the coming together of this idea of a short-term challenge coupled with what happens in the long run that was, to me, a very compelling biologic mystery. And given that the very first biologic finding by John Mason and Earl Giller was the low cortisol, that was almost a paradox, because fight or flight, we talk about high cortisol levels. So it just felt like there was a very juicy story here to pursue. And basically, that's what we've been doing.
And we have a couple more questions around, just bringing so much depth of experience that you have to this conversation. One being this construct of PTSD. And I think I just would love to hear your perspective on how we are thinking about what's wrong with that construct in the first place.
Well, I don't know if I would use the language of what's wrong with it. I think in some ways PTSD is a victim of its own success, right? In the beginning, when PTSD got started, the mandate was to try to let people understand that there were longer term effects of an exposure, because that wasn't really in the zeitgeist and that wasn't really in science. We knew a lot about fight or flight. We knew a lot about what happens when a threat is ongoing or even chronic. But this idea that things could keep going, that a traumatic event initiates a cascade that continues long after the event itself has resolved, or initiates biologic transformation and psychological change, that was a hard sell. And again, it's already been 40 years since 1980 when the diagnosis came out. But I remember the controversy around the diagnosis. So, people who were promoting the idea did a great job, because 40 years later, I think that that PTSD is an overly pervasive concept. Epidemiologic studies show that a far greater proportion of people are exposed to trauma than develop PTSD. So PTSD describes one kind of response to trauma. And we shouldn't make a mistake in the field by thinking about PTSD as a binary variable. You're either fine after trauma or you get PTSD. There are a lot of different kind of changes that can occur following trauma exposure. So a problem is trying to use one concept, a one-size-fits-all, off-the-rack concept, to try to explain the highly personalized and individualized changes that can occur in a given person. So it's important that there's a syndrome, if you will, or kind of a description that is universal. But at the same time, I think it's important to give people the allowance to express a highly individualized response to challenge and traumatic stress.
Mm-hmm. Right. Well, and then, go ahead, Keith.
Yeah, I think that, obviously there's this ongoing conversation in the DSM now around, we have PTSD and there's some push to have other diagnoses that include more of a spectrum approach, complex PTSDs and other types of ways of viewing this, which is, it sounds like that's what you're speaking to.
Yes. I think that what complex PTSD helped us get in touch with is a very important aspect of the conversation, which is when something happens in the course of development really matters a lot. The same event occurring in adulthood can play out very differently if it occurs in childhood. And we know this by studying Holocaust survivors, some of whom were very young during the war and some of whom were a lot older. So how a trauma hits you developmentally, the other aspect of complex PTSD is repeated traumatization, that sometimes it isn't just a moment in time, a single episode of interpersonal violence or a war that can last over maybe a longer but circumscribed period of time. Maybe a complex trauma kind of also speaks to the idea that you could grow up in an environment where you're constantly assaulted and confronted by challenges, so much so that they kind of become part of who you are, and you lose your perspective almost about the fact that it shouldn't be this way, that you don't necessarily need to suffer this kind of abuse. Sometimes it's done by people that you love and trust. So I think complex PTSD introduced a very important nuance, more than a nuance, very important idea of dose of trauma, timing of trauma and development, nature of trauma, repeated traumatizations. And all of this really adds to the conversation about the expectation that a single described syndrome would fit the wide gamut of responses that people might have to a wide range of circumstances.
Right.
Yeah, that makes a lot of sense. I'm really curious about your thoughts around treatments and particularly the conversation around the psychedelic assisted psychotherapies and, of course, MDMA for trauma, and your thoughts on it and where we're headed in terms of treating people with these conditions.
Well, I can tell you what appeals to me about the concept of it. I think that current treatments of PTSD, particularly the gold standard cognitive behavioral treatments, they sometimes assume a lot. One of the biggest assumptions that are made is that a person is absolutely in touch with what the trauma is and can walk into your office saying, this is what happened to me. And there was a clear before and a clear after. And I understand the event very clearly and carefully. And, under those circumstances, and that my symptoms really have to do with the fact that as a result of the event, I think differently. I have a lot of recurring thoughts, nightmares, avoidance. So a cognitive behavioral approach might be very well suited for a clear problem like that. But for many people, the struggle is even trying to identify an event from maybe many events that really changed the trajectory of their lives, or that really mattered in a deep way. And so, again, for people that maybe started early in life, experiencing adversity, or people that have really been challenged in many different ways, or people that might not have a very good narrative to themselves about why they are suffering. and aren't necessarily convinced that their current suffering is a result of any single exposure. For those people, you need maybe a different approach. And the advantage of the psychedelic psychotherapy model is that it doesn't presume a specific trauma, but allows an altered state of consciousness and two therapists by your side to guide an exploration to kind of see what gets identified under a completely conducive state psychologically for that kind of an exploration. And it provides a good period of time. These are 8-hour sessions for traumatic materials that might be a little slow usually in appearing to appear. So again, we're not doing this yet. We're very excited to initiate these studies. It takes a lot of preparation, and we are in the preparation phase. But there was something about it that appealed to me because it is so directed by the trauma survivor. And I think that when it comes to suffering as a result of exposures, a lot of things are a blur. And I add to this part of the conversation of intergenerational trauma, which I think adds a lot of valence. And sometimes people experience hardships from an event that objectively doesn't seem that poignant, but becomes far more so in the context of a parental or ancestral experience like immigration or war or something that the family struggled with. And so being in a state where there are no expectations of the trauma, so you don't have the narration and you don't have to repeat and you don't have to do the homework, you just let it come and you stick with it. And time is not up in 50 minutes or 90 minutes. It just seems like something that I would like to try on behalf of trauma survivors, particularly ones that have failed with other approaches.
And thank you, Rachel. And are you at liberty to talk a little bit about what the protocol is going to look like at the VA and what you're going to roll out?
Well, we're working. No, not yet. Let's not jinx it. we're going through approval processes right now, and be more than happy to talk about the specifics at another time. But we are definitely working with MAPS to develop a protocol that will be able to test it. We're interested in scalability of this treatment, how to make it more adaptable so that it can be administered to a large number of people.
I'm glad that you're paying attention to that aspect of it, because it's going to be a big challenge of how to scale availability of this type of treatment because of the 2 therapist model and all the hours, and it's going to be challenging.
The challenge of all of our therapeutic approaches is something called treatment matching. We have a lot of different approaches out there. What we know for sure is that not everyone responds to everything or to any single thing. But surely it can't be random that one person responds well to one type of therapeutic approach and another person responds well to another. And what we have to do now is harness the best of what we've been able to learn using our molecular and endocrine and neuroimaging tools, and really be able to use those tools to match people to the appropriate treatment and be able to monitor their outcomes, not only psychologically, but really from a biologic perspective. And so, again, we shouldn't go into any even exciting treatment being naive that it'll work on every single person. I think that just sets us up. So what we need to do now is kind of regroup and ask the question of, how can a therapist know what is the best possible algorithm for any specific patient? Because the way that it is now, most people go to therapists, and the treatment that they'll get is the treatment that the therapist knows how to do or feels comfortable doing.
That's true.
There's nothing wrong with that per se if it were all random and if it were all trial and error. But what if it isn't, right? What if there is a more precise way to understand, to use science more efficiently and effectively to be able to determine what is the best method for getting to a transformative change? And notice that I said transformative change because I think we also want to think about what treatment outcomes look like. Whether the big picture involves reducing symptoms or getting a decline in symptom severity, or really allowing people to make positive changes in their lives and get to another level, cross over to the other side, and start to live their lives again. So we really want to think about that as well as what the goals of therapy are. And in the studies you'll read in the literature, a treatment, quote unquote, works for PTSD. If there's a reduction in symptom severity, usually as little as 12 points on a PTSD scale. But when people say they've benefited from therapy, usually they don't just mean that their symptoms got better. They mean that they've been able to sort of unstick themselves from something that has prevented them from moving forward in a positive way. So can you now feel pleasure? Can you now embark on a good relationship? Pursue something that you love to do, not feel guilty that you survived something and others didn't, in a way that lets you really use what happened as a way to honor previous losses. So it's so much more than having fewer nightmares, although obviously having fewer nightmares is very important.
Symptom reduction is the beginning of a process, but not the end, is what I'm hearing you say.
It's a good beginning, and I think that we have. I think we really want to offer hope to trauma survivors that there is another side, and we have to help them understand what that looks like, and then I think that people will engage more in mental health because that's really what we have to do. We have to get people very engaged and then explain exactly what they need to ask for, what it looks like to heal and get better. And when I started my career, a little was known about PTSD, and trying to get people to go to treatment for it was really hard because they would say, why should I go and talk about something that happened in the past? You can't change the past, right? And it was really up to us to explain why you have to talk about the past,
right?
Even though you're not going to change it. So it's just a matter of getting the concepts down right.
Yeah, that makes so much sense. I know that you do have to get going here, so I just wanted to really thank you and really appreciate the work you're doing. It's been pretty influential in my own work as a professional and personally, and I think it's really you're having a large influence in understanding really human suffering is what we're talking about and how to help people. And so I just want to thank you for that as we wrap up here.
Oh, thank you. That's a lovely thing to say. And thank you for your good work and for doing this podcast.
Great. You take care.